In this video, how to stop testosterone replacement therapy and how to restart natural testosterone production after TRT. Before we start, can I also ask you before you explain why some people stop, why they have to stop? Explain.
Yeah, of course.
Yeah, because you said I don't condone stopping. I completely agree, of course, but then he said some people have to stop if there's a shortage in medicine or if they have to go into the military. I don't know. Is that a fact?
Yeah, it's rare. Some people probably stop when they shouldn't, and some people think that they need to, and they don't realize they have other options.
Okay.
In case of military, it's been a little strange, but we've heard from a couple of guys on the groups that hey, I'm going into this special training and 6 months, zero medication. I can't take my testosterone with me. And as much as I dislike pellets as a primary form of treatment for hormones, for the obvious, which we have recorded in the pellet video, I don't want to get into that right now, but there is a time and a place where they can be effective. And this is where, let's say you're going to be away for a period of extended stay, several months or so.
Yeah.
You have no opportunity to take your medications for whatever reason, whether it's logistic or just, legal reasons or whatever it is. And you need to remain on treatment. Perhaps for a man who doesn't really run the risk of, so much like a woman over releasing an androgenic hormone, perhaps looking into pellets for that time frame may be a much better option than coming off and restarting their HPTA and attempting to kind of normalize, if you will, especially when you're going to be in a position of having to perform and, have cognition and all these other things that are important for your safety or safety of other soldiers if you're military. I would not necessarily say these people have to come off. They can look at that option. In a case where someone does have to come off for any reason, and we can go ahead and hypothesize why someone may need to come off, and that's really not the point of this video. The point is to establish how do we come off safely, effectively, avoid crashing, and have the best chance of restarting our own natural production so that we can get back to where we hope to be. And look, we understand that coming off is not going to be optimal, but it also doesn't necessarily have to be living hell if it's done correctly. Will your HPTA recover on its own? Maybe, maybe not. There's no guarantees. If it does, to what level? Again, it's purely anecdotal. We don't know. But hopefully it will recover to a level where your natural levels would have been today had you not began, right? Now, the goal here is not to talk about young guys who are running steroid cycles and doing a quote unquote post-cycle therapy to come back to optimal pre-cycle levels. We're talking replacement therapy, and you have to remember, why did you begin therapy? Because you had a deficiency. So if you feel that you were deficient where it warranted medical intervention, the idea of coming back to a pre-intervention state and somehow miraculously not being deficient is a little bit silly. Best case scenario, you will come back to the level of deficiency you had prior and not worse. So just people need to understand that in advance before they think that, all of a sudden they've been kind of optimal or boosted for 6 months or a year. And now they're going to come off and somehow maintain that level without medication. It just doesn't work that way.
So knowing that, Gil, how to restart natural testosterone production after TRT? What is the safest way?
So before we can discuss how to restart it, my philosophy is always patient education. I don't like to just tell someone do A, B, and C and trust me. I like to tell them do A, B, and C. Here's what A does. Here's what B does. Here's what C does. Here's why we do it the way we do it. And then you're kind of like helping the guy alongside your guidance. So it's kind of like a two-tiered approach instead of just saying, listen to me and don't ask questions. So before we can say, look, do this, I want people to understand why. And in order for them to understand why, they need to understand how the hypothalamus pituitary testicular axis works when it comes to producing hormones. And then when we discuss the protocols for restarting your natural production, it's going to make a lot more sense. Now, I'm a type of learner that likes to utilize all senses. I can't just read a textbook and expect to master the material. This is why videos, I think, are essential for guys who learn that way, because we have visual, we have audible, and we sometimes, you know, touch and feel certain things when we learn. So the most senses you can get involved in your learning process, the better. For that purpose, I want to do a quick screen share and share what the HPTA actually looks like, you know, not necessarily anatomically, but the chart of how the operation works, explain it briefly, and then when we get into the medication aspect, we can get back to it and say, well, here's what we're doing, okay? So bear with me a moment. What I'm gonna do real quick is I'm just gonna do a quick screen share, and then I'm going to maximize this. Can you see this okay, Stephen?
Yes, sure.
Okay, great. So what we have here is essentially the hypothalamus right up here in the brain, if you follow my little marker there. Okay, it's in the posterior subsection of the brain, of the cortex, and it is right up above of where the spinal cord and the brain connect, but it is in the posterior part. In the anterior part, we have our pituitary gland sitting right in the front. So I know this is not exactly drawn to scale, but they're both very small organs. Your hypothalamus is sort of a control mechanism. It is what regulates your body temperature, but it also releases hormones known as gonadotropins. What's interesting about gonadotropins is they are signaling agents, okay? So over here you'll see GnRH. Now the N is a small n, it's part of the gonadotropin word. So Gn stands for gonadotropin, Rh is releasing hormone. So essentially a gonadotropin releasing hormone. This is a hormone that releases gonadotropins out of your pituitary gland. Your pituitary gland releases the gonadotropin known as LH, or luteinizing hormone. So hypothalamus gets a signal, which we'll get back to on the back part of this loop, and it tells it, my T levels are low, help. So your hypothalamus releases GnRH, which goes over to your pituitary gland and tells it to release a luteinizing hormone, gonadotropin. This enters the blood system, or the circulatory system, which is also known as an endocrine hormone. It's released by a gland right into the bloodstream, travels down to your testicles, and your testicles have two types of cells. Over here, for the purpose of testosterone, they're referring to Leydig cells, which are the cells responsible for testosterone production, as we know. And then FSH, which is follicle stimulating hormone, actually acts on a cell known as Sertoli cells. So for the purpose of HPTA Restart for hormones, we're not really going to worry about FSH and Sertoli cells. But when we look at the Leydig cells and how the luteinizing hormone acts on the Leydig cells, they have LH receptors. And once those are stimulated, they go to work and produce testosterone. And then testosterone is also an endocrine hormone in men. It is released by the glands, or the testicles, right into the bloodstream. And there's a little testosterone molecule here for you. And then your testosterone is released into the bloodstream, and it travels to all of the cells in the body, acting on the purpose of what it needs. Now, the way this feedback system works, it's a negative feedback loop. The way negative feedbacks work in the endocrine system is simple, okay? When one aspect rises, the other aspect decreases. So think of it as a seesaw effect. One side goes up, the other side goes down. One side goes down, the other side goes up. What happens here is when testosterone levels drop, this is when GnRH and LH rise. When testosterone levels rise and they travel back to the hypothalamus to activate both androgen and estrogen receptors, okay, because some testosterone, as we know, aromatizes in tissues, and some of that spills back into the serum, presumably, so we can enact on estrogen receptors in other parts of the body, not just local to the tissue. It will essentially signal these receptors to say, look, we have enough. You can go ahead and shut this faucet off now. So this is why it's called the negative feedback loop. When you have low levels, this system begins again. When you have sufficient levels, the faucet is turned off. And this cycle generally will repeat in a healthy male on what's known as a circadian rhythm, or a 24-hour cyclical basis, okay? So at night when you sleep is when your hypothalamus becomes more active in this regard, and your LH will increase, which is why they usually tell guys who are not on therapy, do your blood draw in the morning, because your luteinizing hormone will be peaking in the morning, and so will your natural endogenous testosterone. So when we're testing for primary or secondary hypogonadism, we're also taking into account the time of day that we draw blood. If I drew your blood at 6 p.m. and your LH was low, I need to account for that decline over the course of the day, knowing that your LH would have peaked in the morning. Now, this is why we always laugh and say, why is your physician testing luteinizing hormone when you're on therapy? We know it's going to be 0 because LH and FSH are suppressed. Why are they suppressed? Testosterone levels are always sufficient for guys on TRT. Therefore, the hypothalamus, GnRH, and the pituitary LH and FSH signals are suppressed. So this is what it means to be suppressed, or as they call them sometimes, shut down. So when you come off your therapy and your levels begin to decrease after being on for extended periods, it will take many months, if at all, for this signaling mechanism up here to recognize that I got a job to do, because it's been laid off for so long. It's not going to miraculously kick on like it did in a circadian rhythm. So now what we need to do is we need to stimulate endogenous production. Remember, you're injecting or taking a transdermal or whatever application you're using to get your serum levels up. You are bypassing your testicular function and the signaling agents of your testicles. So in order to wake them up, what we need to do is quite simple. Let me just stop the screen share real quick and get back into what we were doing here. So far, I hope that's clear. If there's anything I missed, Stephen, and you want to touch on, by all means, just let me know and we'll continue from there.
No, that's very clear. So continue. What can we do?
Okay, so remember, we got our testicles responsible for producing our hormone. This is essentially the factory. The factory is closed. We got our hypothalamus and pituitary in the interior part of the brain. This is the workers that are going into the factory to work. Okay, the workers are home and the factory is closed. How do we get this working again? First and foremost, we got to open the factory doors. If workers show up and factory is not working, it's moot. How do we open the factory doors? We get our testicles to start producing testosterone endogenously again. And the way we do that is by stimulating them with sufficient levels of luteinizing hormone. Now, understanding that our pituitary has been suppressed for an extended period of time, to expect it to go ahead and kick out these super physiological levels of luteinizing hormone is not really a realistic expectation, right? Nor would it probably be very good for us if we're looking to sustain this long term. So understanding this faucet is going to be dripped back in shortly, let's get the testicles working again. And the way we do that is by mimicking the luteinizing hormone. And the most common way to do that is with HCG, human chorionic gonadotropin. And we use it at super physiological levels for a short period of time. The goal here again is to blast it back into working. This isn't an indefinite steady state that we're going to be living on. This is a, hey, let's get this going so we can, take over naturally in a couple of weeks. So initially what most guys will do is they're going to run an HCG protocol for about 4 to 6 weeks after the medication or testosterone, presumably, ester, has cleared their system. Why? Because as long as that ester is still in circulation, it is still acting as a suppressor, right? So we go ahead and we estimate rough excretion period based on the half-life after our last injection or application. Creams obviously would be far sooner than an injection would be. And then we begin an HCG protocol, which could be daily or it could be every other day. Again, it depends on the age. It depends on the level of testicular activity prior to beginning. Now, here's another reason why you only get one chance to test your baseline labs, and it's important you do it right. When you first run your labs prior to starting your therapy, when we have a luteinizing hormone level and we have a total and a free T level, this allows us to gauge how effective and efficient your Leydig cells are in endogenous production and how effective and efficient your brain glands are at secreting gonadotropins and gonadotropin releasing hormones. Because if we know that you're a strong primary hypogonadal man, there's no guarantee you're ever going to have any levels whatsoever because you've already had the luteinizing hormone going down and it was insufficient. If you were secondary, okay, then we know that yes, your testicle function is good. However, the chances of your hypothalamus or pituitary coming back are probably lower. So we may approach it differently with regards to treatment options as well as dosing or frequency. This is why it's important to have a lab of a baseline properly done prior to ever beginning. Okay, you know the old saying, you only get one chance to make a first impression. It stands true here as well. Once you've begun treatment, you can never run your LH again and determine what your natural levels were. So again, too many people miss that opportunity, and it's a shame. And we chalk it up to provider error because a lot of them are not educated on the topic. Now, once we have that HCG running for a period of about 4 weeks, you don't have to do this, but if you'd like, you can go ahead and run a lab test. If money's not the issue and you can run several labs, ideally, you'd run a test at this point before introducing anything else to see, is this level of stimulation sufficient to bring my levels up to, again, not TRT levels, but I hate to put numbers on it, 400, 500 total T, 600, right? Am I able to get some level of production of a natural male at that point in my life? And if the answer is yes, now is when you start bringing in the next part of the equation. Generally speaking, you would be using a SERM, S-E-R-M, which stands for Selective Estrogen Receptor Modulator. What these class of medications do is they bind to the estrogen receptors. They're essentially almost like estrogen mimickers, but think of a lock and a key, and the key fits into the lock, but it doesn't open the door. So if you look at like a brand of locks and keys, let's say they have the same brand, sometimes the same brand key will fit in the lock, but it won't turn. This is what a SERM does. It binds to the estrogen receptor, but it does not activate it, okay? But it also prevents another key from coming in. So it doesn't allow the estrogen to actually attach to it. What this does is by blocking without activating, it is telling our hypothalamus and our pituitary gland, I don't have sufficient levels anymore, and I need you to go back to work and never stop working. So they're going to start sending out the GnRH, they're going to start sending out the LH, and they're going to start hitting your Leydig cells in your testicles. And at that point, you're going to start tapering off the HCG and coming off of it with the hopes of these signaling agents replacing the mimicking effect that the HCG had. Now they're taking over. You've woken up your testicles, and now you're waking up the brain to kind of take over the wheel, right, if you will. So you kind of been driving from the back seat, and now you're jumping into the driver's seat, and you're letting your body naturally take over. The goal here is, again, prior to stopping your SERMs, now another 4 to 6 weeks, is to run another lab and say, where's my gonadotropins on top of my total and free T? Because previously we only tested total and free under the HCG protocol. Now we're testing gonadotropins to see if they've been waking up. And then the goal is come off of everything and then give it 4 to 6 weeks and go ahead and test it again. And now you have found your true levels. So you're looking at about a 2 to 3 month protocol of properly waking up your system if it's done correctly. I know that when I was talking about an LH mimicker, I mentioned HCG by name, and with SERMs, I did not. The two most commonly used SERMs are tamoxifen, also known as Novadex, or Clomid, also known as clomiphene citrate. Both of them are SERMs. Both of them have slightly different mechanisms of action. They have different affinities to bind to different areas. Tamoxifen is known more to prevent gynecomastia because it does have a bigger binding affinity around the mammary glands, estrogen receptors, while clomiphene has a stronger impact on the pituitary function. So while clomiphene may sound like a better option here, you do get the double benefit in tamoxifen. And again, I know we always talk about estrogen is not what causes gyno. However, an imbalance of estrogen and androgens, which is very common in this post restart period where your androgens are coming down, but the estrogens linger. Some guys will experience a little bit of a flare up during this time period. Tamoxifen is very efficient at, inhibiting that. It also is a much more, a better side effect profile than Clomid does. Clomiphene is a very nasty drug, and it will cause some depression, some mood swings, and some other issues. It can also cause, it blocks the estrogen receptors in the back of the optic nerve in the eye, and it can cause some floaters and some hyperopia and some other issues that may become irreversible. I am not a fan of the drug. I think that's pretty evident in everything that we always discuss. So if you have an opportunity to use tamoxifen in place of clomiphene, I'm a fan of that. And yeah, I think a lot of guys are using way too much, and they are using it for too long, and they're just not going about it correctly. It's not that serious. You have two things you got to restart. You do them correctly at the right doses, you do them in the correct order, and then you go ahead and you retest to see if you've recovered correctly.
Mm-hmm. Okay, if man would do this restart protocol as you just told it, as it should be done, what can they expect to feel? Are there any side effects or symptoms? Are they going to feel depressed, crashed? Are the
Good
low T
question.
symptoms coming back?
Yeah, there's no umbrella answer for this because, as we know, hormones are very individualistic. Look, I'm sure you've come across guys who are absolutely tanked, and you look at their labs and you say, "How are you even walking the earth?" And they say, "I don't know, I feel fine." And then we got guys in the 700s who tell you, "I feel, I'm suicidal and I feel like death, and my joints are, singing a symphony when I walk." So it's really individual. The short answer, the safe answer here, which I think would encompass the vast majority of the people, is that you're not going to feel as good as you did on TRT. I mean, this is evident. So I think it's safe to say you're going to crash from where you were. Are you going to crash and burn? I mean, the goal here is no. The goal here is to preserve something. If you don't do this properly, you may crash and burn. You may actually go into a complete shutdown and be in abysmal numbers, which not only impact the quality of life, but your health. I mean, your ability, bone mineral density, your heart health, physiological health is going to be impacted. So the goal here is to bring you back to where you would have been. Look, if you're a 45-year-old male and you were deficient at age 44, the goal with this therapy is not to optimize you. It is to take you off something for whatever reason and bring you to where you would have been at age 45 had you not started. Now, if you were deficient at 44, the presumption is that at 45 you would be equal or worse off than you were a year ago. So what can they expect? They can expect to be where they were prior to starting or worse. They're never going to miraculously recover to a better level. And even if the numbers are transiently better, it's a non-lasting issue. I mean, again, if you truly got on TRT for the right reasons, which was to fix a medical deficiency, okay, I know a lot of guys get on it for the sake of getting on it and they really didn't need you in the first place, they may be just fine. But if you truly got on it for medical protocol, and you have fixed a deficiency and you're doing well and you're coming off for whatever reason, understand that coming off is not going to have any residual benefits from the time you were on. You're going to lose those. And at the best case scenario, you're only going to lose them to the level you had before.
Mm-hmm. Is your experience that a lot of doctors that will be asked for help in this are knowledgeable in this matter, or what's your experience?
My experience doesn't make me happy here because my experience is no. A lot of providers are not experienced in actually administering replacement therapy correctly, let alone getting someone off of therapy. The problem is that the underground world of bodybuilding, which has been long tutored for anabolic use, has far more experience than the medical community in doing what we just discussed. However, they do it to an extreme. They overload it. They use way too big of a dose. They kind of, there's a lot of bro science involved. And even then, it is still better than what a lot of the medical community is doing because the medical community isn't trained on this. They don't do it. And, I see all the time, and we hear all the time of doctors just taking guys off for the wrong reasons to begin with. But even then, they just say, well, stop cold turkey, or I want you off for the next 3 months. And the worst I've heard is I've heard a guy local to us, we have some of his patients coming in recently saying 3 months out of every year, he takes you off everything so that your body can recover, so that your body can produce. It doesn't, I mean, you're putting people in a 3-month hell, and then you're destroying any progress and stabilization and homeostasis that you've established for them. And then you're starting from scratch. And his theory is if you come off for 3 months every year, your body is never truly suppressed. And it's the most idiotic thing I've ever, I don't understand how this guy went to med school and he doesn't understand the HPTA or basic endocrinology. But again, it's a shame. And unfortunately, the norm is incorrect. And look, the reason we do this every weekend is to try to change this. And the more people that watch these and the more people that share it and keep an open mind, look, we're here to learn. None of us know it all, right? But when you have an ego and you say, leave me alone, I don't need to learn anything and I'm done and just don't talk to me, or go watch your YouTube videos or go in your Facebook groups and don't ask me. What you're doing is you're not only depriving yourself the opportunity to educate and learn something that you're not going to be taught in school, but you're now depriving all of your patients from being done correctly. Look, take the video and watch it. Don't take our word for it. Take the science, research it yourself. Look at studies, look at evidence. If what we say makes sense, Take from it what you will and use it in your practice. If what we say makes zero sense, chalk off the last 10 minutes for 10 minutes less that you spend on Netflix. Not a big deal, okay? I watch a ton of videos. I read a ton of stuff from a ton of different people, and then I check it. And if it makes sense, I used to tell guys, okay, I'll admit this right now. I used to tell guys 3-4 years ago, don't use aromatase inhibitors. I always disliked them. But I did say, if you're that symptomatic where you feel that your estradiol is elevated, use a small dose. There is no clear-cut number, but use a small dose if you're symptomatic, because that's what I thought at the time, based on the research we had and discussions and experience. I thought that was the approach. It wasn't until Jordan Grant sent me over the papers on where aromatization happens and how it is a self-regulated tissue level hormone, not an and then I thought to myself, you know what, we always knew it's not an endocrine hormone in men. I mean, we don't have ovaries. How do we produce? We don't produce estrogen. We aromatize. The question is, where was it being aromatized? At that point, I had a light bulb go off, and I said, holy cow, we should never touch an aromatase inhibitor. I've been wrong. And I'm saying it right now, and I've said it in the past. I was wrong. But I wasn't wrong because I was ignorant, and I wasn't wrong because I had an ego that said, I know it all. I was wrong because up until that point, that was the information I was working with. And as soon as new information that is evidence-based and scientific came to light, I took the merits of the source, which brought it to me, and I said, yeah, you know, this guy knows his stuff. Let me read it. And I read it, and I said, holy cow, he's right. And then I went ahead and I changed my course. So if more people did that and actually had open discussions and not just shunned away information because this is how it's done, this is how I was taught, and I don't want to hear anything else, a lot less men and women would be suffering out there. So our goal is to get information out there and encourage patients and providers alike to listen to the information, process the information, have discussions, and then come to your own conclusions. No one is handcuffing you, but we're providing free information. It's a resource, it's a tool, and if you don't use it, that's on you.
Exactly, Gil. That's exactly why I started the YouTube channel, the Facebook group. I have all you guys joining in regularly, and I learn a ton still every day. So thank you for all of this explanation, Gil. If people would want to reach out to you, how can they reach you?
Easiest way to find me is right on my nutrition website. It's www.nextleveldietetics.com.
As always, the link will be in the description of the video. Thanks, Gil.
Thanks, Steve, and stay safe.